Welcome to the Deep Dive. We're the show that really aims to empower you with the knowledge to truly master complex topics. And today, we are taking a plunge, a really deep one, into a battle that's constantly unfolding. It's happening right now at the molecular level.
Right.
We're talking about the ingenious ways our most powerful antibiotics take on bacterial infections. Have you ever stopped to wonder how these vital medicines actually work? I mean, right down to jamming a bacterium's internal machinery.
It's a really fascinating area, isn't it? And often we just see this drug works, but we don't always appreciate the incredible how that underpins its effectiveness.
Yeah, exactly.
Understanding these precise molecular mechanisms, well, it truly unveils a whole new level of insight.
And that's absolutely our mission today. We're going to embark on a deep dive into a really crucial class of antimicrobial agents, the protein synthesis inhibitors. Now, these aren't just general bug killers, right? They are like exquisitely designed drugs that specifically target the bacterial ribosome.
That's the key, the ribosome.
Think of it like this. If a bacterium is a tiny factory, its ribosomes are the essential assembly lines. They build all the proteins it needs to survive, to multiply.
Right, everything.
These drugs, then, are basically master saboteurs. They stock those assembly lines cold.
And our goal today isn't just to, rattle off a laundry list of facts. We really want to equip you with a comprehensive, nuanced understanding of these vital drugs.
We want you to master this information.
Exactly. To gain insights that are comparable to the elite professionals working in this very field. So understanding not just what these drugs do, but really why they do it and what the actual real-world implications are.
And to get to that level of mastery, we've pulled together a pretty robust stack of sources. We're primarily drawing a foundational understanding from the authoritative medical and pharmacological text, GOODMAN and GILMAN's The Pharmacology.
Gold standard, really.
Right. So this isn't just a surface skim. We're going deep. Really deep into the intricate mechanisms of how these drugs work, their specific activities against all sorts of different bacteria, the clever ways bacteria develop resistance, which is a huge topic, and of course the crucial practical implications for each major group of these inhibitors.
So what's on the itinerary? What are we covering?
Good question.
We'll journey through the major drug classes that fall under this umbrella. We've got the versatile tetracyclines and their modern derivatives. Then the widely used macrolides and ketolides.
Okay.
The powerful lincosamides, thinking clindamycin there. The newer oxazolidinones. The intriguing pleuromutilins.
Right, those are interesting.
The synergistic streptogramins. The, historically significant phenicols like chloramphenicol. And finally, the specialized topical agent, mupirocin.
Wow, that's quite a list.
It is. And it's important to note right from the start, most of these agents are primarily bacteriostatic.
Okay, so what does that mean exactly? Static versus cytal.
Good point. Bacteriostatic means they generally halt bacterial growth. They stop the bacteria from multiplying, putting a stop to the infection's spread, basically giving your immune system a chance to catch up and clear it.
Rather than directly killing the bacteria, which would be bactericidal.
Precisely. But like with any complex biological system, we'll certainly uncover some fascinating exceptions and nuances to that rule as we go along. Some can be cytal under certain conditions.
All right, sounds like a plan. Let's begin our deep dive with our first major category, the tetracyclines and their derivatives. They often get called the four-ring wonders.
Aptly named.
Because their fundamental chemical structure is built around, a core four-ring system. Doxycycline is probably the classic example most people might recognize of that foundational structure.
Yeah, that four-ring structure, it's the heart of the class. It really defines the entire group. Today in the U.S., for systemic use, the ones you'll commonly encounter are dimethylcycline, tetracycline itself, minocycline, and, as you said, doxycycline.
Workhorses.
Absolute workhorses. They've been mainstays in medicine for decades.
What's really remarkable, though, I think, is how science has adapted. How it's evolved this class to combat that ever-present challenge of bacterial resistance.
It's an arms race, isn't it?
Totally.
Yeah.
Over the past 20 years or so, we've seen the introduction of newer derivatives. These were specifically engineered to overcome those bacterial defenses. We're talking about things like the glycylcyclines, with tigecycline being the main one there. Then there are the fluorocyclines, like ervocycline, and the aminomethylcyclines, like amatocycline.
Right, these newer generations.
Yeah, and they aren't like entirely new drugs in the sense of a completely different class. They're actually tetracycline congeners. They share that core four-ring structure.
Still tetracyclines at heart.
Exactly. But what makes them special are these specific chemical substituents, these extra bits attached to that core.
The modifications.
Right. These additions grant them a truly broad spectrum of activity. And impressively, even against many bacteria that have become resistant to the older tetracyclines.
Which is huge.
It's a brilliant example of, chemical modification restoring clinical utility. Really clever stuff.
So let's pull back the curtain a bit. How do they actually work? Their mechanism of action, or MOA. Tetracyclines they're precision tools. They zero in on the bacterial ribosome, specifically binding to the 30S subunit.
30S, got it.
Their particular function is to prevent something called aminoacyl tRNA, which is basically the delivery truck carrying the next amino acid for the growing protein chain from accessing what's known as the acceptor, or the A site, on the mRNA ribosome complex.
So it blocks the loading dock, essentially.
Pretty much. If that delivery truck can't dock at the A site, the protein assembly line just grinds to a halt. It's like blocking the entrance ramp to a busy highway. Nothing new can get on.
Okay, makes sense. So how do these drugs actually get inside the bacterial cell to do their job? Especially thinking about gram-negative organisms, which have that pretty formidable outer membrane.
Yeah, that outer membrane is a barrier. It's actually a two-step entry process. Quite ingenious, really.
Okay.
First, tetracyclines passively diffuse through tiny channels. These are formed by proteins called porins in that outer cell membrane. Think of these porins as small, sort of selective doorways.
Okay, step one, get through the outer door.
Right. But that's just the first hurdle. To get across the inner membrane, the cytoplasmic membrane, the bacteria actually have active transport pumps. And ironically, tetracyclines effectively hijack these pumps.
Wait, they use the bacteria's own machinery against it?
Exactly. They use the bacteria's own machinery to get themselves pumped inside.
Yeah.
It's truly a molecular Trojan horse maneuver.
That's brilliant and kind of devious.
It is. And once inside, tetracyclines get to work. Now, they are typically bacteriostatic antibiotics.
Or static halting growth.
Their primary role is to halt the growth and multiplication of bacteria, not necessarily kill them outright. And while they have a broad spectrum of activity, there's an interesting nuance. They're intrinsically more active against gram-positive microorganisms than gram-negative ones.
Why is that?
Well, this difference largely comes down to a clever defense mechanism that many gram-negative bacteria possess the ability to actively efflux tetracyclines.
The pumps again, but working the other way.
Exactly. Literally pumping the drug back out of their cells before it can build up to effective concentrations and do its work.
Okay, so let's dive into specifics. Which bacteria are they good against? What are the susceptibilities?
Right. The picture is quite dynamic here. For common pathogens like Streptococcus pyogenes and penicillin-susceptible Streptococcus pneumonia, the older tetracyclines generally show good activity.
Okay.
However, it's that constant arms race we mentioned. Resistance is unfortunately common among group B Streptococci and also among penicillin-resistant S. pneumonia.
But what about staph, especially MRSA?
Yes. Here's a significant advantage. Tetracyclines, including doxycycline and minocycline, maintain good activity against both methicillin-sensitive Staphylococcus aureus, or MSSA, and crucially, methicillin-resistant Staphylococcus aureus, MRSA.
That is a big deal.
It's huge in the fight against antibiotic-resistant superbugs.
Okay. What about enterococci?
Those can be tough.
They certainly can. And here we see how the newer generations of tetracyclines have really expanded their reach. Earlier agents had pretty limited impact. But with agents like tigecycline and eravacycline, we now observe good activity against multi-drug-resistant enterococcal isolates, which are notoriously difficult to treat.
Good to know. Any others?
On a more specific note, Bacillus anthracis, the causative agent of anthrax, is typically susceptible. This makes tetracyclines relevant in, critical public health and bioterrorism preparedness scenarios.
Right, definitely important. What about the challenging gram-negatives then, besides the efflux issue? Well, the activity of older tetracyclines against Haemophilus influenza has largely been retained, which is good news for common respiratory infections. Okay. However, for many Enterobacterales, that's a large family, including pervasive pathogens like E. coli resistance to the earlier generation agents, has unfortunately become quite widespread.
Yeah, you hear about that a lot with E. coli.
Exactly. And this is where the innovation of the newer drugs really shines. While, say, a significant portion of E. coli isolates might be resistant to older tetracycline, you see a dramatic improvement with minocycline, and even more so with ticycline and eravacycline.
Ah, okay.
It's a clear illustration of how these newer drugs are specifically designed to circumvent those older resistance mechanisms. But despite these advances, it's still important to remember that even newer agents show poor activity against Proteus species.
Okay, Proteus is still tough. What about the non-fermenters, like Pseudomonas?
Ah, critical point. Among non-fermenting gram-negatives, Pseudomonas aeruginosa is intrinsically resistant to tetracyclines.
Intrinsically resistant, meaning just forget about it for Pseudomonas.
Pretty much. Simply put, these drugs will not work against it. So if Pseudomonas is suspected, you need a totally different class of antibiotic.
Got it.
However, there's some good news for other difficult pathogens in this group. Burkholderia species, Acinetobacter species, and Stenotrophomonas maltophilia are often susceptible.
Okay.
Minocycline, tigacycline, and eravacycline, in particular, demonstrate greater activity against these challenging organisms. And the story continues to improve with the newer tetracycline derivatives, which also show increased activity against anaerobic gram-negatives, like Bacteroides fragilis, which are often implicated in things like abdominal infections.
Wow. Okay, so beyond those groups, the overall reach of tetracyclines sounds pretty remarkable.
It truly is. They are effective against most strains of Brucella Haemophilus ducreyi, that's the cause of chancroid, and a range of Vibrio species, including Vibrio cholerae and Vibrio vulnificus. They also inhibit the growth of Campylobacter jejuni. Helicobacter pylori, a key player in ulcers, as you know, Yersinia pestis the plague. Yersinia enterocolitica, Francisella tularensis, tularemia, and Pastorella multicida.
A real rogues gallery of pathogens.
Indeed. And for specific conditions like actinomycosis, which often responds well to penicillin, tetracyclines can be a valuable and effective alternative treatment.
What about things like rickettsia or chlamydia, those intracellular bugs?
Ah, yes. What's particularly powerful about tetracyclines is their effectiveness against microorganisms that are intrinsically resistant to cell wall active agents, drugs like penicillin that target the bacterial cell wall.
Okay.
This unique profile makes them invaluable for treating infections caused by pathogens like rickettsia, think of Rocky Mountain spotted fever, also Coxiella burnetii, which causes Q fever, Mycoplasma pneumonia, and Chlamydia SBP, which are common causes of respiratory and sexually transmitted infections.
Right, the atypicals.
Exactly. They're also active against Legionella, SPP, ureaplasma, some atypical mycobacteria, and even certain Plasmodium species, which cause malaria.
Malaria too, wow.
Yes. Furthermore, they demonstrate activity against a wide range of spirochetes, including Borrelia recurrentis, Borrelia burgdorferi, the bacterium behind Lyme disease, Treponema pallidum, the cause of syphilis, and Treponema pertinue. Their versatility across such diverse pathogens is really a cornerstone of their clinical utility.
It's incredible, but with such widespread and long-standing use, it's kind of inevitable, right? Bacteria fight back.
The ultimate survival artists.
So let's talk resistance mechanisms. You mentioned they're often plasmid-mediated.
Yes, frequently plasmid-mediated. This means the resistance genes are carried on these small circular pieces of DNA that can, unfortunately, be easily transferred between bacteria, sharing the secrets, so to speak.
Uh-oh.
What's more, these mechanisms are often inducible, meaning the bacteria only switch on their resistance defenses when the antibiotic is actually present. Very efficient from their perspective.
Sneaky. So what are the main ways they resist?
There are three primary ways bacteria resist tetracyclines. First, and quite common, is decreased accumulation.
Okay.
This occurs either because the antibiotic simply can't get into the cell as effectively, that's reduced influx, or, more frequently, the bacteria deploy an energy-dependent efflux pump.
The bouncers again?
Exactly, like molecular bouncers, actively expelling the tetracycline molecules back out of the cell as quickly as they enter. This effectively keeps the internal concentration too low to be effective.
Okay, number one is pumping it out or keeping it out. What's number two?
Second, bacteria can produce what's ingeniously called a ribosomal protection protein.
A shield.
That's a great way to think of it. This protein literally binds to the bacterial ribosome and physically displaces the tetracyclines from their target site, making the antibiotic ineffective. The TEAM gene is a classic, well-studied example of this mechanism. It's essentially a shield that protects the ribosome from the drug.
Wow, that's clever.
Yeah.
And the third way?
And third, though it's less commonly observed, resistance can also arise from the enzymatic inactivation of tetracyclines by bacterial enzymes, sometimes referred to as destructases.
They just chew up the drug.
essentially.
Hmm.
Or, alternatively, a specific mutation at the ribosomal target site itself can occur, which makes the drug bind less effectively. While these are less frequent, they definitely add to the complexity of bacterial defense strategies.
Okay, so with these different mechanisms, efflux, protection, inactivation, how much cross-resistance do we see? If a bug is resistant to one tetracycline, is it resistant to all of them?
Ah, good question. It heavily depends on which mechanism is primarily at play.
Okay.
For instance, if a bacterium is resistant because it's deploying a ribosomal protection protein, like the one encoded by the TM gene, that resistance typically extends across older agents like doxycycline and minocycline. However, minocycline, and to a lesser extent doxycycline, are generally a bit more resilient against efflux pumps. They often show lower minimum inhibitory concentrations, or MICs, against bacteria that primarily use efflux for resistance, although cross-resistance can certainly still occur.
So this is where the newer guys come in. Tigecycline, ervacycline, almetacycline.
This is precisely where the newer agents, the glycylcyclines, fluorocyclines, and aminomethylcyclines, truly shine in overcoming resistance. Their structural modifications are specifically designed to reduce their affinity for most bacterial efflux pumps.
Ah, so they don't get kicked out as easily.
Exactly, which is absolutely crucial for restoring activity against many organisms that have become tetracycline resistant through that specific efflux mechanism.
Okay.
Beyond that, their binding to the bacterial ribosomes is also enhanced, which means they can often overcome those ribosomal protection proteins that confer resistance to other tetracyclines.
So they bind tighter too.
Yes. These targeted molecular-level modifications represent a significant advance in staying ahead, or at least trying to stay ahead, in the antimicrobial arms race.
Okay, really fascinating. Let's turn now to the practical side, ADME. Absorption, distribution, metabolism, and excretion. How these drugs actually behave in your body. This is key for effective treatment, right?
Absolutely crucial. And oral absorption of tetracyclines varies quite a bit depending on the specific agent.
Okay.
For example, omadacycline has about 33% oral absorption, meaning only about a third of what you take actually gets into your bloodstream.
Oh, great.
But for doxycycline and minocycline, that figure jumps much higher to around 90%, much better.
Okay.
It's also critical to know that tigecycline and eravacycline are only available for intravenous or IV administration. You won't find them in pill form, parenteral only.
Right. Now, you mentioned something earlier about interactions with castications, like calcium.
Yes, an absolutely crucial interaction to remember. It's what happens when you take tetracyclines with divalent or trivalent locations.
Okay, break that down. What are those?
We're talking about common dietary components in supplements, like calcium, think dairy, magnesium and aluminum in antacids, iron, and zinc supplements.
Stuff people take all the time.
Exactly. These cations can chelate or bind tightly with the tetracycline molecules right there in your gut. They form an insoluble complex.
It's like a little chemical handcuff.
Pretty much. And this significantly impairs the drug's absorption, making it far less effective. This is why patients must rigorously avoid dairy products, antacids, aluminum hydroxide gels, and calcium, magnesium, iron, or zinc supplements, as well as bismuth subsalicylate when taking most tetracyclines.
Wow.
It's a simple interaction with really profound implications for whether the drug actually works or not.
That's a practical tip worth repeating. Avoid dairy, avoid antacids, avoid those mineral supplements when taking these.
For most of them, yes. Critically important.
What about food in general? Does that interfere?
Good question. The good news for patient convenience is that food, including dairy products, does not interfere with the absorption of doxycycline and minocycline.
Okay, so those two are okay with food.
Yes. So those can be taken with meals, which can sometimes help with stomach upset. However, for omadacycline, the story is very different. Food significantly impairs its absorption.
Significantly.
Yes. To ensure optimal effectiveness, omadacycline must be administered on an empty stomach. That means at least 4 hours after and 2 hours before a meal.
Wow, that's quite specific.
It's a strict rule to ensure you're actually getting the full benefit from the drug. Very important counseling point.
Okay, so once they're absorbed, how long do they stick around? What are the kinetics like?
Once absorbed, the pharmacokinetics typically show that peak plasma concentrations are attained within about 2 to 4 hours after a single oral dose.
Okay.
Most of these drugs have half-lives ranging from 6 to 12 hours. This often dictates that they need to be administered 2 to 4 times daily to maintain effective levels in the body, keep the drug levels up.
Makes sense. And where do they go in the body? Distribution.
When we talk about distribution, tetracyclines spread widely throughout the body. They reach therapeutic concentrations in various fluids and tissues, including the urine and the prostate.
Okay.
They also have a unique tendency to accumulate in certain cells, the reticuloendothelial cells of the liver, spleen, and bone marrow. And crucially, they also deposit in bone, dentine, and the enamel of unerupted teeth.
Ah, the teeth staining issue we hear about.
Exactly. This accumulation in developing bone and teeth, as we'll definitely discuss more under adverse effects, is a key reason for their restricted use in young children and pregnant women.
Okay. What about the newer ones, tigecycline and eravacycline? They're IV only.
Yes, and their distribution pattern is particularly noteworthy. They exhibit rapid and extensive distribution into body tissues.
That sounds good for tissue infections.
Often, yes. But while this is beneficial for tissue-based infections, it results in relatively low serum levels, low levels in the bloodstream itself.
Why is that a problem?
This could be a critical consideration because these low serum levels may actually be inadequate to effectively treat bacteremias, infections in the blood, especially those originating from endovascular sources like infections of the heart valves.
Ah, okay. So great for tissue, maybe not ideal for bloodstream infections.
It's a classic example of how a drug's distribution profile can really influence its clinical utility. Another interesting point is that, unlike many other antibiotics, tetracyclines readily cross the meninges and enter the cerebrospinal fluid, or CSF, even without inflammation.
Really? Even without meningitis?
Yes, they also readily cross the placental barrier, entering fetal circulation and amniotic fluid, and relatively high concentrations are found in breast milk. All important factors.
Oh, okay. So how does the body get rid of them? Elimination.
The elimination pathways vary by the specific tetracycline. Tetracycline and dimethylcycline are primarily cleared by the kidneys, but they also undergo significant concentration in the liver, excretion into the bile, and then partial reabsorption through what's called enterohepatic recirculation, a cycle where the drug is reabsorbed from the gut back into the circulation.
A little recycling loop.
Kind of. Doxycycline and omadacycline are largely excreted unchanged in both the bile and the urine. This is a practical advantage because it means no dose adjustment is typically needed for patients with renal dysfunction, with kidney problems.
That's convenient.
Tigecycline and eravacycline are mostly excreted unchanged, with a small amount of metabolites. Importantly, they do require specific dosage adjustments for patients with severe hepatic impairment, severe liver problems.
Okay, liver adjustment for those two.
And minocycline, uniquely, is extensively metabolized by the liver before it's excreted. So different pathways for different drugs.
Got it. Okay, now let's explore the therapeutic uses. You said they're versatile, so where do we actually use them?
Right, their uses truly highlight their remarkable versatility. The early generation tetracyclines, despite their age, remain invaluable as first-line therapy for infections caused by Rickettsia, mycoplasmas, and chlamydia.
Those specific bugs they're good at hitting?
Exactly. Their unique spectrum against these specific pathogens makes them indispensable.
And doxycycline is the main one today, right?
Doxycycline, being the most widely used tetracycline today, is a true workhorse. It's a drug of choice for a vast array of conditions.
Wow.
Many sexually transmitted diseases, various rickettsial infections, serious zoonotic diseases like plague, brucellosis, and tularemia.
Wow.
It's also a go-to for many spirochetal infections like Lyme disease. Beyond that, it's frequently used for common respiratory tract infections and for skin and soft tissue infections, particularly when MRSA is suspected, given its activity against that challenging pathogen.
So doxycycline covers a lot of ground. What about minocycline?
Minocycline, while perhaps not as broadly used as doxycycline, offers critical utility for doxycycline-resistant strains of MRSA.
Ah, okay. Step up for resistance.
Yes, and also for Acinetobacter species and certain non-tuberculous mycobacteria. This really underscores its role in tackling more difficult-to-treat infections.
And the newer agents, tigecycline and the others.
The newer agents, the glycylcyclines, fluorocyclines, and aminomethylcyclines, have been a real game changer. They have successfully restored much of the antibacterial activity that was unfortunately lost to resistance with the older tetracyclines.
That's the goal.
Their in vitro activity against a significant number of resistant gram-positive and gram-negative organisms is truly impressive, offering new hope against multi-drug resistant threats.
But I think I remember reading something, a caution about tigecycline.
Yes, that's an important point. A pooled analysis of tigecycline clinical trials revealed a small but statistically significant increased risk of death compared to other antibiotics used as comparators in those trials.
Increased risk of death.
Yes, this led to its reservation as more of an alternative therapy in some scenarios, highlighting that careful balance we always have to strike between efficacy and safety. Interestingly, while arafacecycline and omadacycline show promise against multi-drug-resistant gram-negatives, particularly those often found in urinary tract infections, or UTIs, neither agent fully met the criteria for non-inferiority in randomized trials, specifically for complicated UTIs.
They didn't perform as well as hoped for UTIs. Why?
It was likely due to their relatively poor accumulation in the urine. Getting good urine levels is crucial for treating urinary infections effectively. So their distribution pattern worked against them in that specific indication.
Back to distribution. Makes sense. Okay, let's dig into some specific clinical applications. Respiratory infections.
Yes. Tetracyclines demonstrate good activity against typical respiratory pathogens like S. pneumonia, H. influenza, and Moraxella catarrhalis. But where they truly excel is against those atypical pathogens.
Mycoplasma, chlamydia.
Exactly. Mycoplasma and Chlamydophila pneumonia. These are common causes of pneumonia that often don't respond well to traditional beta-lactam antibiotics like penicillin or amoxicillin. Doxycycline is frequently recommended as a single agent for uncomplicated community-acquired pneumonia, or CAP, in outpatient settings. Or it can be used as an adjunctive agent combined with beta-lactams for more complicated CAP cases that require hospitalization.
Right, covering all the bases.
It's also a common treatment for acute exacerbations of chronic bronchitis and for sinusitis. And both ticycline and omadacycline are, in fact, FDA approved for treating adults with community-acquired bacterial pneumonia.
Okay. What about skin infections? You mentioned MRSA coverage.
Yes, for skin and soft tissue infections, doxycycline and minocycline show good activity against Staphylococci, making them valuable tools for cutaneous infections, especially when MRSA is suspected as the culprit.
Good oral option for MRSA skin stuff.
Exactly. Ticycline and omadacycline have specific FDA approvals for complicated skin and soft tissue infections, the more serious ones. And in a unique, much lower dose application, tetracycline at just 25 milligram orally twice a day has a long history of use in treating acne.
Right, acne treatment. Okay. Intra-abdominal infections,
Yeah.
like after surgery or appendicitis.
Yeah. In the realm of intra-abdominal infections, the older tetracyclines unfortunately have pretty limited utility now due to widespread resistance among enterobacteriales and gram-negative anaerobes.
Okay, not great for those.
However, ticycline and aravacycline are a different story. They possess excellent activity against these pathogens, as well as Enterococcus. And crucially, they hold specific FDA indications for the treatment of complicated intra-abdominal infections.
So the newer ones are good here.
Yes, this is a significant advantage in managing those often tricky polymicrobial infections frequently found in the abdomen.
Okay. Sexually transmitted diseases or STDs. Where do tetracyclines fit in now?
The landscape is always evolving here. Doxycycline is unfortunately no longer recommended for gonococcal infections due to widespread resistance, so you need a different approach for gonorrhea itself.
Okay, no good for gonorrhea. What about chlamydia?
Yes, for uncomplicated genital infections caused by Chlamydia trachomatis, a 7-day course of doxycycline is actually considered more effective than a single dose azithromycin regimen.
More effective than the Z-Pak for chlamydia. Interesting.
It is. Doxycycline is also a key component of combination therapy regimens for acute pelvic inflammatory disease, or PID, C. trachomatis, is often a coexisting pathogen in those cases.
Okay.
For acute epididymitis, which can be caused by C. trachomatis or Neisseria gonorrhoeae in younger men, effective regimens often combine a single injection of ceftriaxone with doxycycline for 10 days. And it's important to remember that sexual partners should also be treated.
Right.
Doxycycline for 21 days is the first-line therapy for lymphogranuloma venereum, or LGV. And for non-pregnant patients with a penicillin allergy who have primary, secondary, or latent syphilis, a 2-week doxycycline regimen can be used as an effective alternative.
And not neurosyphilis.
Critically, no.
Yeah.
Tetracycline should not be used for the treatment of neurosyphilis. This is mainly due to concerns about penetration into the central nervous system and the need for higher, more reliably bactericidal activity for that serious condition.
Okay. Very important distinction. What about zoonoses, diseases from animals?
Yes, for zoonoses, tetracyclines are truly life-saving, particularly in rickettsial infections such as Rocky Mountain spotted fever, various forms of typhus, rickettsial pox, and Q fever. They are also highly effective in treating ehrlichiosis and anaplasmosis.
So for tick-borne stuff, mainly.
A lot of tick-borne illnesses, yes. Doxycycline is the undisputed drug of choice for Rocky Mountain spotted fever, ehrlichiosis, and anaplasmosis. And this is so critical that it's even recommended for children less than 9 years of age.
Even with the tooth staining risk.
Yes. In these potentially life-threatening infections, the seriousness of a potentially fatal outcome dramatically outweighs the relatively small, though real, risk of permanent tooth staining. Benefit clearly outweighs risk.
Understood. What about Lyme disease?
Doxycycline is also a first-line treatment for adults dealing with infections caused by Borrelia species, including Borrelia burgdorferi, the bacterium that causes Lyme disease. For acute and chronic infections caused by Brucella species, tetracyclines are highly effective when used in combination with rifampin or streptomycin. And while streptomycin might be preferred sometimes, tetracyclines are also a strong treatment option for tularemia.
Anthrax.
Yes. Doxycycline plays a critical role in the prevention or treatment of anthrax. For the more serious inhalational or gastrointestinal forms, it should be used in combination with another agent, and the recommended duration of therapy is a prolonged 60 days for bioterrorism exposures, reflecting the need for thorough prophylaxis against potential spore germination.
60 days. Wow. Okay. Any other infections worth mentioning?
Just a few more to highlight their breadth. While actinomycosis is most responsive to penicillin G, it can also be successfully treated with a tetracycline as an alternative. Minocycline serves as an alternative for treating nocardiosis, though it should usually be used concurrently with a sulfonamide for best efficacy. Tetracyclines are also useful in both the acute treatment and prophylaxis of leptospirosis. They found utility for susceptible, atypical mycobacterial pathogens, including Mycobacterium marinum, which can cause skin infections, often from fish tanks or contaminated water.
Yeah, okay.
And very notably, tetracyclines, when strategically combined with bismuth, metronidazole, and a proton pump inhibitor, that's the classic quadruple therapy, constitute a first-line therapy regimen for H. pylori infections, a common cause of peptic ulcer disease.
Right, H. pylori eradication. Okay, that's a huge range of uses.
Right.
But now we have to talk about the downsides. The adverse effects. What are the main concerns with tetracyclines?
Yes, the adverse effects can range from mild to quite serious. Gastrointestinal irritation is probably the most common issue, especially after oral administration.
Like stomach upset.
Exactly. Patients might experience epigastric burning and distress, abdominal discomfort, nausea, vomiting, and diarrhea. Often taking the drugs with food can help alleviate these symptoms.
But not dairy or antacids for most of them.
Precisely. No dairy products or antacids for most, as they chelate the drug, except for doxycycline and minocycline, which are okay with food. And omadacycline specifically must be taken on an empty stomach due to that significant food interference.
Okay.
There's also a risk of esophagitis and esophageal ulcers. This is why patients should always take oral formulations with a full glass of water while standing or sitting upright. This helps ensure the pill clears the esophagus quickly and doesn't just sit there irritating the lining.
Good practical tip. Take with lots of water. Stay upright.
Yes. And for IV tigecycline, nausea and vomiting can unfortunately be severe enough in some patients to actually limit treatment.
What else?
Photosensitivity is another important concern. Individuals treated with tetracyclines, especially the older ones maybe, may experience exaggerated skin reactions, like getting severely sunburned when exposed to sunlight.
So wear sunscreen and a hat.
Absolutely. Our recommendation is always to reduce sun exposure and use strong sunscreen diligently during therapy. Less commonly, something called onycholysis, where the nail separates from the nail bed and pigmentation of the nails can occur, sometimes with or without photosensitivity.
Okay. What about liver or kidneys?
Hepatic toxicity or liver damage has been observed, particularly in patients with pre-existing renal failure who were receiving high doses, typically 2 grams or more per day, parenterally. It can also occur with large oral doses. Pregnant women appear to be particularly susceptible to this side effect, making careful consideration essential during pregnancy.
Okay. And kidneys?
In terms of renal toxicity, tetracyclines can potentially aggravate azotemia in patients with pre-existing kidney disease. Azotemia just means an excess of nitrogenous waste products like urea in the blood.
So they can strain struggling kidneys.
Yes. Due to their catabolic effects, they can increase the breakdown of body proteins, putting more load on the kidneys. However, it's a critical distinction that doxycycline, minocycline, and tigecycline generally have fewer renal side effects compared to other tetracyclines. They're often safer options for those with kidney issues.
That's good to know.
Interestingly, dimeclocycline can uniquely cause nephrogenic diabetes insipidus, a condition where the kidneys can't properly concentrate urine. This side effect has actually been therapeutically exploited sometimes for managing SIADH, the syndrome of inappropriate secretion of antidiuretic hormone, where the body retains too much water.
Weird side effect becomes a treatment. Huh.
Yeah. A more serious, albeit rare, renal issue is Fanconi syndrome. It's characterized by a cluster of symptoms like nausea, vomiting, excessive urination, and thirst, along with specific changes in urine composition like protein and glucose in the urine. This syndrome has been definitively linked to ingesting outdated tetracycline, presumably due to toxic breakdown products forming over time. So never use expired tetracyclines.
Definitely not. Okay, now the big one. Bone and teeth.
Yes, one of the most historically significant and well-known adverse effects. Children treated with tetracyclines can develop a permanent, irreversible brown discoloration of their teeth. Permanent. The total quantity of antibiotic administered seems to be more important than the exact duration of therapy. The risk is highest when the drug is given to infants before their first dentition erupts. But it can also develop if the drug is administered between the ages of 2 months and 5 years, a critical period when permanent teeth are calcifying.
And in pregnancy.
Similarly, if pregnant patients are treated with tetracyclines, their children may experience this same tooth discoloration. There's also a theoretical concern about potential depressed bone growth due to tetracycline deposition in the growing skeleton during gestation and childhood, though this seems less commonly observed clinically than tooth staining.
So the bottom line is avoid in pregnancy and young kids unless absolutely necessary.
For these compelling and permanent reasons, yes. Tetracyclines are generally avoided in pregnant women and children less than 8 years old, unless there's a life-threatening compelling indication, such as Rocky Mountain spotted fever, where the immediate benefit of a potentially life-saving treatment dramatically outweighs the long-term risk of tooth discoloration.
Benefit versus risk, always. Any other toxic effects?
A few others are worth noting. Thrombophlebitis, which is inflammation of a vein, can occur after intravenous administration. This local irritative effect has actually been used therapeutically in patients with malignant pleural effusions, where inducing a desired inflammatory response can help seal the space and prevent fluid reaccumulation.
Another side effect during treatment.
Yeah. Long-term tetracycline therapy can lead to changes in blood counts, like leukocytosis, increased white cells, atypical lymphocytes, toxic granulation of certain white cells, and thrombocytopenic purpura, a bleeding disorder from low platelets. Tetracyclines may also cause increased intracranial pressure, a condition sometimes known as pseudotumor cerebri, in young infants, even at usual doses.
Increased pressure in the head?
Yes. And minocycline specifically is known for causing vestibular toxicity. This manifests as dizziness, ataxia, loss of coordination, nausea, and vomiting. These symptoms usually appear relatively soon after the first dose and generally resolve within 24 to 48 hours after stopping the drug.
Dizziness from minocycline, okay.
And like most medications, rare skin reactions, including severe allergic responses like angioedema, swelling, and anaphylaxis, can occur even after oral use.
Right. Always a risk. Okay, last thing for tetracyclines. Drug interactions, we cover the cations. Anything else?
Yes. Besides the crucial cation chelation issue, there is some evidence of drug interactions between doxycycline and hepatic enzyme-inducing agents. Things like phenytoin, an anti-seizure med, and rifampin, an antibiotic often used for TB. These inducers can speed up doxycycline's metabolism by the liver, potentially leading to lower subtherapeutic drug concentrations, meaning the doxycycline might not work as well. However, this interaction hasn't really been observed with minocycline or tigecycline, which is a helpful distinction. Eravacycline, on the other hand, is a substrate of CYP3A4, a key drug metabolizing enzyme.
The CYP enzyme.
Exactly. This means its concentrations can be significantly reduced by strong CYP3A4 inducers like rifampin, potentially making it less effective. And conversely, its levels can be increased by strong CYP3A4 inhibitors, such as itraconazole, an antifungal, potentially increasing side effects. This necessitates careful monitoring and potential dose adjustments when used with those types of drugs.
Okay, lots to consider with tetracyclines. Let's shift our focus now to another widely used and clinically significant class, the macrolides and ketolides.
Yes, these are hugely important, particularly valuable for combating respiratory tract infections, especially those caused by the typical community-acquired pneumonia pathogens.
So who are the players in this class?
In the United States, we currently have 4 macrolides available for clinical use. There's erythromycin, which was the original agent discovered way back in 1952.
The OG macrolide?
Pretty much. Then we have clarithromycin and azithromycin. These are actually semi-synthetic derivatives of erythromycin, and their improved profiles better tolerated. Broader spectrum in some ways have largely led them to replace erythromycin in routine clinical practice.
Okay. And the fourth?
The fourth is fidaxomicin. This one is unique. It's not systemically absorbed, meaning it stays primarily in the gut, and it's exclusively used for treating Clostridium difficile colitis, or C. diff.
Ah, the C. diff specialist.
Exactly. Then we have the ketolides, a closely related group. This includes telithromycin, cethromycin, and solithromycin. These are also semi-synthetic derivatives of erythromycin, ingeniously designed to be active against some macrolide-resistant bacterial strains.
Okay, so macrolides and ketolides, what defines them structurally?
At their core, macrolide antibiotics are structurally defined by a large, multi-membered lactone ring.
A big ring structure.
Yes, for erythromycin and clarithromycin, it's a 14-membered ring. For azithromycin, it's a slightly larger 15-membered ring. To this ring, one or more deoxysugars are attached. The structural differences between these agents are subtle, but have profound impacts. Clarithromycin differs from erythromycin only by the methylation of a hydroxyl group at one position. Azithromycin introduces a methyl-substituted nitrogen atom right into its lactone ring.
Small changes, big effects.
Precisely. These seemingly small chemical modifications are actually quite significant. They lead to improved acid stability, meaning the drugs are less broken down by stomach acid, enhanced tissue penetration, allowing them to reach infection sites more effectively, and importantly, a broadened spectrum of activity in some cases.
And the ketolides, how are they different?
Ketolides, while sharing that multi-membered ring system, feature different key substituents. For example, a 3-keto group replaces a sugar moiety found in macrolides, and there's a strategically placed carbamate group.
Why those changes?
These specific structural alterations are incredibly important because they make ketolides less susceptible to two common resistance mechanisms: methylase-mediated resistance, governed by genes, and efflux-mediated resistance, governed by MEF or MISR genes.
Ah, so they overcome some resistance.
That's the idea. This means ketolides can be active against many gram-positive strains that have become resistant to other macrolides. However, it's worth a crucial mention that safety concerns surrounding telithromycin led to its significantly limited use, and its manufacturer even stopped marketing it in the U.S.
Oh, safety issues.
Yes, and similarly, development of cethromycin and solithromycin has either been halted or stalled after unfavorable FDA reviews, casting some uncertainty over their future.
Okay, so how do these macrolides and ketolides actually work? Mechanism of action.
In terms of their mechanism, both macrolide and ketolide antibiotics are generally bacteriostatic agents.
Static again, halting growth.
Right. Their primary effect is to inhibit bacterial growth and replication, giving the body's immune system a chance to clear the infection. However, it's a bit of a spectrum, and at higher concentrations, they can actually be bactericidal, meaning they kill bacteria against particularly susceptible organisms.
Okay. How do they do it?
They achieve their effect by reversibly binding to the 50S ribosomal subunits of sensitive microorganisms, the larger subunit this time.
50S. Got it. Not the 30S like tetracyclines.
Correct. 50S erythromycin's specific action on the ribosome is quite interesting. It doesn't directly prevent the formation of the peptide bond itself. Instead, it interferes with the translocation step.
Translocation? What's that?
That's the crucial movement where a newly synthesized peptidyl tRNA molecule shifts from the acceptor site, A site, to the peptidyl donor site, P site, on the ribosome. This advances the protein chain. By jamming this movement, erythromycin effectively halts protein synthesis.
Like throwing a wrench in the assembly line gears?
Exactly. Alternatively, it's thought that macrolides might also bind in a way that causes a conformational change, subtly altering the ribosome's shape, which then indirectly interferes with both transpeptidation, the bond formation, and translocation. A significant difference in accumulation is also noteworthy. Gram-positive bacteria can accumulate about 100 times more erythromycin than gram-negative bacteria, which contributes significantly to its stronger activity against gram-positives.
Ah, they get more drug inside them. Okay. Let's talk antimicrobial activity. What bugs do they hit? Erythromycin first.
Right. Erythromycin, while often bacteriostatic, can be bactericidal at high concentrations. It shows reasonably good activity against streptococci, but it's a key point that macrolide resistance among S. pneumonia often coincides with penicillin resistance.
So if it's resistant to penicillin, it might be resistant to erythromycin too.
Often, yes. Staphylococci are not reliably sensitive to erythromycin, And macrolide-resistant strains of S. aureus may also exhibit cross-resistance to clindamycin and streptogramin B. Gram-positive bacilli, like Clostridium perfringens, Corynebacterium diphtheria, and Listeria monocytogenes, are frequently sensitive. However, it's important to remember that erythromycin is generally inactive against most aerobic enteric gram-negative bacilli, like E. coli.
Okay, not great for gram-negative rods. Any gram-negative, it does hit.
Despite that, it does show modest in vitro activity against Haemophilus influenza and Neisseria meningitidis, and good activity against most strains of N. gonorrhea. Useful antibacterial activity is also seen against Pastorella multocida, Borrelia species, like Lyme, and critically, Bordetella pertussis, the bacterium that causes whooping cough.
Whooping cough, okay.
Macrolides are also typically active against Campylobacter jejuni. Erythromycin is further active against Mycoplasma pneumonia and Legionella pneumophila, both common causes of atypical pneumonia, and most strains of Chlamydia trachomatis are effectively inhibited by erythromycin as well.
So strong on the atypicals and some specific others. How do azithromycin and clarithromycin compare?
When we compare azithromycin and azithromycin exhibits pretty similar activity to erythromycin against sensitive strains of Streptococci and Staphylococci. Clarithromycin is generally considered slightly more potent against these. However, here's a crucial distinction regarding H. influenza. Clarithromycin is somewhat less active than erythromycin against H. flu, whereas azithromycin stands out as the most active macrolide against that particular organism.
So azithromycin is the go-to for H. flu among the macrolides.
Generally, yes, it has the best activity there. Both clarithromycin and azithromycin show excellent activity against Moraxella catarrhalis, Chlamydia species, Legionella pneumophila, Borrelia burgdorferi, Mycoplasma pneumonia, and Helicobacter pylori.
Covering a lot of the same ground, but with that key difference for H. flu.
Right. Their enhanced activity also extends to some non-tuberculous mycobacteria, as well as certain protozoa like Toxoplasma gondii, Cryptosporidium, and Plasmodium species, highlighting their versatility beyond typical bacterial infections.
Protozoa too. Interesting.
Yes. Clarithromycin, specifically, is also known for its good activity against Mycobacterium leprae, the causative agent of leprosy. The spectrum of activity for ketolides, like telithromycin, broadly mirrors clarithromycin and azithromycin. However, their unique structural modifications are key. They are designed to bypass many of the common macrolide resistance mechanisms.
Right, overcoming resistance.
Which significantly increases their in vitro activity against macrolide-resistant S. pneumonia and S. aureus, offering a potential solution in challenging resistance scenarios, although, again, hampered by those safety and development issues we mentioned.
Okay, and fidaxomicin, just C. diff.
And then there's fidaxomicin, truly unique. It's specifically engineered for potent activity against Clostridium difficile, while having minimal impact on other beneficial gut flora. This highly specialized design means it has essentially no clinical utility for infections beyond C. difficile colitis, making it a very targeted treatment.
Okay, now resistance. How do bacteria fight back against macrolides and ketolides?
Bacterial resistance to this class typically arises from one of four main mechanisms. Clever strategies, really.
Let's hear them.
First, there's drug efflux. Bacteria actively pump the antibiotic out of their cells using specialized protein pumps, like having a dedicated bilge pump just for the antibiotic.
Pumping it out, got it.
Second, and quite common, is ribosomal protection. This involves the bacteria producing methylase enzymes, either when induced by the drug or just all the time, constitutively.
What do the methylases do?
These enzymes chemically modify the ribosomal target site where the macrolide is supposed to bind. This modification decreases the drug's binding affinity, making it much less effective. It's a sophisticated way for the bacteria to directly shield their protein-making machinery, modifying the target.
Okay, shield the ribosome.
Third, macrolides can be hydrolyzed, or basically broken down, by enzymes called esterases, produced by certain bacteria, particularly those in the Enterobacterialis family. This enzymatic breakdown directly inactivates the drug, rendering it useless.
Showing up the drug again. And number 4.
And finally, resistance can stem from chromosome mutations that alter a specific 50S ribosomal protein. This structural change in the ribosome itself prevents the macrolide from binding effectively. This mechanism has been observed in various bacteria, including Bacillus subtilis, Campylobacter species, different mycobacteria, and certain gram-positive cocci, showcasing diverse pathways to resistance.
Efflux, protection, hydrolysis, mutation, lots of ways. Okay, let's talk ADME for macrolides. Erythromycin first. It's acid sensitive, right?
Yes, erythromycin base is incompletely absorbed from the upper small intestine. Because it's sensitive to stomach acid and can be inactivated there, it's typically formulated as enteric-coated tablets or capsules designed to dissolve later in the gut, bypassing the stomach's acidity.
Okay.
Food might also delay its absorption. Esters of erythromycin base, like stearate, estolate, and ethylsuccinate, were engineered to have improved acid stability, and their absorption is less affected by food, offering more flexibility. Erythromycin is about 70% to 80% protein-bound. It crosses the placenta, with fetal plasma concentrations ranging from about 5% to 20% of maternal levels. Concentrations in breast milk are about 50% of serum levels. Erythromycin is concentrated in the liver and primarily excreted in the bile. Its serum half-life is relatively short, around 1.6 hours. A dosage reduction isn't routinely recommended in general renal failure and is not significantly removed by dialysis.
Okay, clarithromycin. How's it different?
Clarithromycin is rapidly absorbed orally, but it undergoes significant hepatic first-pass metabolism, meaning a chunk of the drug is metabolized by the liver before it even reaches the rest of the body. This reduces its bioavailability to about 50–55%.
Okay, half gets knocked out first pass.
Roughly. Peak concentrations are usually reached about 2 hours after administration. Clarithromycin can generally be given with or without food, but the extended-release formulation should be taken with food to improve its bioavailability. Both clarithromycin and its active metabolite, 14-hydroxychlorothymicin, achieve remarkably high intracellular concentrations throughout the body, including in places like the middle ear, which is beneficial for ear infection.
Gets into cells well.
Very well. Clarithromycin is metabolized in the liver to several metabolites, with that 14-hydroxy metabolite being the most significant active one. The elimination half-lives are approximately 3 to 7 hours for clarithromycin and 5 to 9 hours for its active metabolite. Its metabolism is saturable, meaning at higher dosages the pathways can get overwhelmed, leading to nonlinear pharmacokinetics and longer half-lives.
Okay.
About 20% to 40% of the dose is excreted unchanged in the urine, with another 10% to 15% as the 14-hydroxy metabolite. Dose adjustment is generally only recommended if kidney function is significantly impaired, like a creatinine clearance below 30 millibirds per minute.
Okay. Now, azithromycin, the Z-Pak drug, it has that really long half-life, right?
Yes, azithromycin, when given orally, is absorbed rapidly but incompletely, with bioavailability around 30–40%. It distributes widely throughout the body, though notably not effectively to the brain or CSF, so not for CNS infections. It can also be given intravenously. Azithromycin has truly unique pharmacokinetic properties. It exhibits extensive tissue distribution and achieves remarkably high intracellular concentrations, particularly within phagocytes, your body's immune cells.
So it hangs out in immune cells.
It does. This results in much greater concentrations of the drug in tissues and secretions compared to what's floating around in the serum at the same time. It undergoes some hepatic metabolism to inactive metabolites, but biliary excretion is its major route of elimination, largely cleared via bile into the feces. Only about 12% is excreted unchanged in the urine.
And the long half-life.
Its elimination half-life is remarkably prolonged, ranging from 40 to 68 hours. This is largely due to this extensive tissue sequestration and binding. It just hangs around in tissues for a long time. This long half-life is exactly what allows for convenient once-daily or even that famous 5-day Z-Pak dosing, or even once-weekly dosing for some indications like MAI prophylaxis.
Makes sense now. And phytoxamicin stays in the gut.
Lastly, fidaxomicin, as we mentioned, is specifically designed for localized action within the gut. It achieves very high levels within the gut lumen and stool, exactly where it needs to be to fight C. difficile. Critically, it is minimally absorbed into the bloodstream. Peak plasma levels are incredibly low. Over 90% of the administered dose is recovered in the stool as either the parent drug or its metabolite. Minimal systemic absorption is precisely what makes it ideal for C. difficile colitis.
Perfect for a gut infection. Okay, let's talk uses. Dosing first.
Right dosing. For adults, erythromycin used to be 1–2 grams a day divided, but it's used less now. Clarithromycin is typically 250–500 milligrams twice daily, or an extended release 500 milligrams once daily. Standard doses of azithromycin are 250–500 milligrams orally, or IV once daily, thanks to that long half-life. There are specific regimens for certain infections, like the Z-Pak.
Okay. Respiratory infections seem like a big use case.
Exceptionally well suited. Azithromycin and clarithromycin are excellent choices for treating community-acquired pneumonia in low-risk outpatients, especially where macrolide resistance in S. pneumonia isn't too high.
Right.
For outpatient CAP, pharyngitis, or sinusitis, that common regimen is a 500 milligram loading dose on day 1, then 250 milligrams daily for days 2 through 5. In hospitalized patients with more complicated CAP, a macrolide is often added to an antipneumococcal beta-lactam
Why add it?
to provide crucial coverage against those atypical respiratory pathogens, mycoplasma, chlamydia, legionella, which beta-lactams might miss, covers all the likely culprits.
Makes
Macrolides are also appropriate alternatives for acute exacerbations of chronic bronchitis, acute otitis media, acute strep pharyngitis, and acute bacterial sinusitis. For kids with ear infections or pneumonia, azithromycin dosing is weight-based, often a 5-day course, or sometimes even a single high dose for otitis media. Generally, azithromycin and clarithromycin are widely preferred over erythromycin due to broader spectrum and much better tolerability. Fewer GI side effects.
Okay, what about skin infections?
For skin and soft tissue infections, macrolides can serve as valuable alternatives for things like erysipelas and cellulitis, especially for patients with serious penicillin allergies. Erythromycin used to be an alternative for minor staph skin infections, but again, resistance is a major issue now. Many Escherichia strains are macrolide resistant, so you really need to know susceptibility if you're relying on it for staph.
Okay, STIs. We mentioned doxycycline being better for chlamydia now.
Yes, the role has evolved. A single 1-gram dose of azithromycin can be used to treat uncomplicated non-gonococcal urethritis, presumed chlamydia.
Right.
However, that 7-day course of doxycycline is generally considered more effective.
Okay.
The 1G azithromycin dose is effective for chancroid. Generally, chlamydial infections can be treated with macrolides. Erythromycin base is notably preferred for chlamydial pneumonia of infancy and ophthalmia neonatorum in newborns. Azithromycin might be used for LGV.
Okay. Diphtheria and pertussis.
For diphtheria, erythromycin for 7 days is very effective for treating acute infections or eradicating the carrier state. Other macrolides aren't FDA approved for this. And crucially, antibiotics don't alter the acute course or risk of complications from diphtheria toxin. Antitoxin is the primary critical treatment.
Got it. Antitoxin first.
For pertussis, whooping cough, erythromycin stands as the drug of choice for treatment and post-exposure prophylaxis for contacts. Clarithromycin and azithromycin are also effective alternatives. If given early, erythromycin might shorten the illness duration, but less effect once the severe coughing starts. Resistance has been reported, so follow-up is key.
Okay. H. pylori. Ulcers.
Yes. In the treatment of H. pylori infection, clarithromycin at 500 milligrams is a key component of first-line triple therapy. It's typically combined with a proton pump inhibitor like omeprazole and amoxicillin twice daily for 10-14 days. Powerful combination.
Right. Triple therapy, mycobacterial infections, like TB relatives.
Yes, for mycobacterial infections, clarithromycin or azithromycin are recommended as first-line therapy for both prophylaxis and treatment of disseminated MAI, Mycobacterium avium intracellulaire, infection in HIV patients, and also for treating pulmonary MAI disease in non-HIV patients. Often used in combination with drugs like ethambutol, sometimes rifabutin. Either clarithromycin or azithromycin can also be a vital component of combination therapy for other challenging non-tuberculous mycobacterial infections, like Mycobacterium abscessus. Clarithromycin has also been used with minocycline for leprosy,
M. leprae.
and C. diff, only fidaxomicin, right?
Lastly, for Clostridium difficile infection, fidaxomicin, 200 milligrams orally twice daily, is as effective as oral vancomycin and, importantly, is associated with a lower risk of relapse. A big advantage for recurrent infections.
Okay.
It's critical to understand that other macrolides are generally not effective for C. diff, and in fact, their use might even predispose patients to getting C. diff, though maybe less risk than some other broad-spectrum antibiotics.
Okay, fidaxomicin for C. diff, others avoid. Got it. Now, adverse effects. What are the big ones for macrolides? GI upset seems common.
Yes, gastrointestinal toxicity is frequently observed, especially with oral or IV erythromycin moderate to severe epigastric distress. And there's that fascinating side effect. Erythromycin actually stimulates GI motility by acting on motilin receptors in the gut.
The prokinetic effect. Exactly. Which is why it's sometimes used off-label to help stimulate gut movement in ICUs or for diabetic gastroparesis.
Right.
While clarithromycin and azithromycin can also cause GI distress, it's typically much less severe than with erythromycin.
Okay. What about the heart? QT prolongation.
Yes, cardiac toxicity is a significant and important concern. Erythromycin, clarithromycin, azithromycin, and telithromycin have all been linked to cardiac arrhythmias, including QT prolongation on an EKG. In severe cases, this can lead to a dangerous ventricular tachycardia called torsades de pointe.
That sounds serious.
It is. A large cohort study found a small but statistically significant increased risk of sudden cardiac death with azithromycin compared to no antibiotic or amoxicillin. This highlights the need for careful risk assessment. Patients with pre-existing risk factors like electrolyte imbalances, underlying heart disease, or those already taking other drugs that prolong the QTC interval warrant particular caution and close monitoring.
Okay, heart risk is real. Liver toxicity.
Hepatotoxicity, specifically a form called cholestatic hepatitis, is associated with long-term treatment with erythromycin. It typically begins after 10-20 days with nausea, vomiting, cramps, then potentially jaundice, fever, and elevated liver enzymes. Does it go away? Fortunately, these findings usually resolve within days after stopping the drug. While less common, hepatotoxicity has also been observed with clarithromycin and azithromycin, though at a lower rate than with erythromycin and the ketolide telithromycin.
Okay. Anything else? Hearing issues, allergies.
Other toxic effects include allergic reactions like fever, eosinophilia, high eosinophil count, and skin eruptions. These generally disappear shortly after stopping therapy. Auditory impairment and tinnitus, a ringing in the ears, have also been observed with macrolides, especially at higher doses.
Okay. Drug interactions. You mentioned CYP enzymes earlier.
Yes, this is a very important area for macrolides. Erythromycin, clarithromycin, and telithromycin are strong inhibitors of CYP3A4.
The major drug metabolizing enzyme.
Right. This inhibition can lead to significant drug interactions because these macrolides can potentiate or strengthen the effects of many other drugs metabolized by CYP3A4.
Like what kinds of drugs?
Widely used ones like carbamazepine, corticosteroids, cyclosporine, digoxin, certain ergot alkaloids, theophylline, triazolam, valproate, and importantly, warfarin. By inhibiting metabolism, macrolides cause increased levels of these other drugs, raising the potential for toxicity. Big interaction potential.
So you really have to check meds if starting one of these.
Absolutely. Conversely, co-administration of rifampin, a powerful CYP inducer, might decrease the serum concentrations of clarithromycin and telithromycin, potentially making them less effective. And other CYP3A4 inhibitors, like itraconazole, can increase the levels of clarithromycin and telithromycin.
What about azithromycin? Less interaction.
Azithromycin is a notable exception here. It's much less likely to be involved in these significant CYP-mediated drug interactions, which is a major advantage. However, even with azithromycin, caution is still advised, especially when the consequences of an interaction, however rare, could be severe.
Okay, good to know azithromycin is generally safer on the interaction front. Let's move to our next class. The lincosamides. Clindamycin is the main one here, right?
Yes, clindamycin plays the starring role in clinical practice. The class originator, lincomycin, and clindamycin are both approved in the U.S., but clindamycin has largely supplanted lincomycin due to its improved profile. It's primarily utilized for treating gram-positive aerobic and anaerobic infections, and also some parasitic infections.
How does clindamycin work? Mechanism?
Its mechanism is quite precise. Clindamycin binds exclusively to the 50S subunit of bacterial ribosomes, thereby suppressing protein synthesis.
50S again, like macrolides.
Yes. What's fascinating is that while clindamycin, erythromycin, and chloramphenicol are not structurally related at all, their binding sites on the ribosome are in very close proximity.
So they kind of bump into each other.
Effectively, yes. This means that if one of these antibiotics binds to its site, it can physically inhibit the binding and action of the others. This is crucial for understanding potential drug interactions and overlapping resistance patterns within this group. They can interfere with each other.
Okay. What's its spectrum? What bacteria does it cover well?
In terms of antimicrobial activity, clindamycin exhibits good in vitro activity against penicillin-susceptible strains of pneumococci, though its activity is less robust against penicillin-resistant strains. It's also effective against Streptococcus pyogenes and viridin streptococcus.
Staph MSSA. MRSA.
Methicillin-sensitive Staphylococcus aureus, or MSSA, is usually susceptible to clindamycin. But a critical point is that MRSA and coagulase-negative staphylococci are more likely to be resistant, requiring careful susceptibility testing. Don't assume MRSA coverage.
Okay. Where does it really shine?
Where clindamycin truly shines is its activity against anaerobic bacteria. It's notably more active than macrolides in this regard, especially against Bacteroides fragilis, a very common anaerobe found in the gut and involved in abdominal infections.
Strong on anaerobes? Good.
Yes. However, it's important to note that resistance to clindamycin in Bacteroid species is increasingly encountered. Also, around 10% to 20% of Clostridial species, other than C. perfringens, can be resistant. Strains of Actinomyces israeli and Nocardia asteroides are generally sensitive. Critically, nearly all aerobic gram-negative bacilli are resistant to clindamycin.
Okay, definitely not for E. coli or Pseudomonas.
Definitely not.
What about those parasitic infections you mentioned?
Yes, clindamycin also plays a significant role in combination regimens for specific parasitic infections. For instance, clindamycin plus primaquine is a valuable second-line regimen for pneumocystis jirovecii pneumonia, or PCP, particularly in HIV patients.
Okay.
And clindamycin plus paramethylamine is used as a second-line regimen for Toxoplasma gondii encephalitis, another important application in immunocompromised individuals.
Got it. Resistance to clindamycin. You mentioned overlap with macrolides.
Yes, there's a strong connection. Specifically, macrolide resistance that results from ribosomal methylation, that gene mechanism, can also confer resistance to clindamycin.
Okay.
However, it's an important distinction that clindamycin itself does not induce the methylase enzyme. Therefore, cross-resistance to clindamycin only occurs if the enzyme is constitutively produced by the bacteria, meaning it's always on.
Ah, only if the resistance is always active.
Right. It's also important to note that prolonged exposure to macrolides can select for a subpopulation of these constitutive methylase producers among Staphylococci and Streptococci that initially only had a macrolide-inducible phenotype. So macrolide use can drive clindamycin resistance.
Interesting.
Here's a clever nuance, though. Clindamycin is not a substrate for macrolide efflux pumps.
Ah, so if resistance is just due to the pump.
Exactly. Bacterial strains that are resistant to macrolides specifically due to an efflux mechanism will still be susceptible to clindamycin, offering a potential therapeutic window. You need to know the mechanism.
That's key. Okay, ADME of clindamycin. Absorption.
It's truly excellent. Nearly completely absorbed after oral administration, which is a major advantage for outpatient therapy. Very high bioavailability.
Great.
Peak concentrations of 2 to 3 micrograms per milliliter are typically reached within about an hour after a 150 milligram dose. Importantly, food in the stomach does not significantly reduce its absorption, offering flexibility for patients.
Okay. Half-life.
The antibiotic's half-life is relatively short, about 3 hours. So it generally requires more frequent dosing, maybe every 6 to 8 hours, compared to something like azithromycin.
Right.
Clindamycin palmitate, an oral preparation specifically used for pediatric patients, is an inactive prodrug that is rapidly hydrolyzed in vivo to the active compound. Similarly, the phosphate ester of clindamycin, which is administered parenterally via injection, is also rapidly hydrolyzed in vivo to the active parent compound.
Okay. Distribution. Does it get into bone?
CSF. Once absorbed, clindamycin distributes widely into many body fluids and tissues. It achieves good concentrations in bone, making it useful for bone infections, osteomyelitis.
That's for bone.
Yes. However, its concentrations in the cerebrospinal fluid, or CSF, are limited, even when the meninges are inflamed. So this generally restricts its use for meningitis. But concentrations sufficient to treat cerebral toxoplasmosis can still be achieved, showcasing that specific clinical niche.
Okay.
The drug readily crosses the placental barrier, important for pregnant patients. Over 90% of clindamycin is bound to plasma proteins. It also has a unique and beneficial property. It accumulates in polymorphonuclear leukocytes, neutrophils, alveolar macrophages, and within abscesses.
Gets into immune cells and abscesses. That's useful.
Highly advantageous for treating infections in these challenging, often walled-off sites.
How is it eliminated? Metabolism.
Clindamycin is inactivated by metabolism in the liver to N-dimethylclindamycin and clindamycin sulfoxide. These inactive metabolites are then excreted in the urine and bile.
So liver metabolism is key.
Yes. Because of this significant hepatic metabolism, dosage adjustments may be required in patients with severe hepatic failure. Only about 10% of the administered clindamycin is excreted unaltered in the urine, with small quantities also found in the feces. Mostly metabolism.
Okay. Therapeutic uses. How is it typically dosed?
The oral dose of clindamycin for adults is typically 150 to 300 milligrams every 6 hours for mild to moderate infections, or 300 to 600 milligrams every 6 hours for severe infections. For children, the dosage is weight-based using the palmitate form.
10-4.
For serious infections, intravenous or intramuscular administration is recommended for adults at dosages of 1,200 to 2,700 milligrams per day, divided into 3 or 4 equal doses.
Of course.
Children also receive weight-based IV dosing.
Okay. Where is it most useful? Skin infections.
Yes, in skin and soft tissue infections, clindamycin is a very valuable alternative, especially for patients with beta-lactam allergies. It provides a crucial option there. It's also useful for oral treatment of skin infections, particularly when MRSA and streptococci are suspected pathogens, assuming the strain is susceptible. Because clindamycin has that unique ability to inhibit toxin production by certain bacteria.
Yeah, the antitoxin effect.
Exactly. It's recommended as an adjunctive agent in severe infections like necrotizing fasciitis or gas gangrene, particularly when toxin-producing bacteria like streptococci, staphylococci, or clostridia are suspected. This antitoxin effect is a key differentiator from many other antibiotics. Additionally, topical clindamycin is a commonly used and effective treatment for acne vulgaris.
Okay. Respiratory infections. You mentioned anaerobes.
Yes, for respiratory tract infections, clindamycin is highly effective for treating lung abscess and anaerobic lung and pleural space infections due to susceptible organisms, reflecting its strength against anaerobes. It has also been used as an alternative agent for treating sinusitis, pharyngitis, and otitis media. And in HIV patients, clindamycin, in combination with primaquine, is a useful and important alternative agent for the treatment of pneumocystis jirovecii pneumonia, PCP.
Bone infections.
Other uses. Clindamycin's good activity against staphylococci and its excellent bone penetration make it a solid alternative agent for the treatment of osteomyelitis, which can be notoriously difficult to treat.
Right.
In other infections, clindamycin, when combined with pyrimethamine and leucovorin, is an effective alternative for the acute treatment of encephalitis caused by Toxoplasma gondii in patients with AIDS. Clindamycin plus quinine is also an alternative regimen for non-severe malaria. And for bacterial vaginosis, clindamycin is a common and effective treatment administered vaginally as a cream or ovule.
Okay. Quite a few niche uses, too. Now, the big one for clindamycin, adverse effects. C. diff risk, right?
Yes, let's address the adverse effects, which include some significant concerns. Gastrointestinal effects are common, with a reported incidence of diarrhea ranging from 2% to 20% of patients. Usually mild to moderate, resolves on stopping the drug. However,
Here it comes.
clindamycin carries a relatively high and well-documented risk of superinfection with Clostridium difficile. This leads to C. difficile infection, or CDI, which can be serious and potentially fatal colitis.
How high is the risk compared to others?
One meta-analysis found an odds ratio of about 16 for CDI with clindamycin compared to no antibiotic exposure. That's substantially higher than for cephalosporins or fluoroquinolones, which were around 5.5. So it definitely carries a higher risk.
Wow, 16 times the risk.
This Clostridium difficile colitis is characterized by watery diarrhea, fever, and elevated peripheral white blood cell counts. Severe forms can indeed be fatal. The prescribing information for clindamycin in the U.S. includes a prominent boxed warning specifically about this risk, underscoring its gravity.
The black box warning.
Yes. Treatment typically involves immediately stopping clindamycin and starting treatment with oral vancomycin or fidaxomicin. Unfortunately, relapses can occur. It's also critically important to avoid agents that inhibit peristalsis, like opioids, dopamide for example, as they may prolong and worsen the condition by keeping the toxins in the gut longer.
Don't slow down the gut if you have C. diff. Got it. What other side effects? Rashes.
Other toxic effects include skin rashes, which occur in about 10% of patients treated with clindamycin and may be more common in individuals with HIV infection. Uncommon but potentially more severe reactions include exudative erythema multiforme, also known as Stevens-Johnson syndrome, a severe skin reaction, reversible elevation of liver enzymes, granulocytopenia, low granulocytes, thrombocytopenia, low platelets, and anaphylactic reactions can also occur, though rarely.
Okay.
Local thrombophlebitis, inflammation of the vein, may occur following IV administration. And an important note for surgical settings. Clindamycin may potentiate the effect of concomitant neuromuscular blocking agents used during anesthesia.
Good to know for anesthesiologists. Okay, let's move on to the oxazolidinones. These are newer, right? Linezolid.
Yes, the oxazolidinones, a relatively new and critically important class of synthetic protein synthesis inhibitors. These drugs are primarily active against gram-positive organisms, including many of those multi-drug-resistant pathogens that continue to pose significant challenges. Linezolid is the class originator, marking a real breakthrough. And a second agent, tetazolid, received FDA approval in 2014, expanding our options.
How do they work? What's their unique mechanism?
Their mechanism of action is quite unique among protein synthesis inhibitors. Oxazolidinones work by binding to the P site of the 50S ribosomal
I'll
subunit.
say on the 50S. Okay.
What truly sets them apart and makes them so effective against resistant strains is their specific action. They prevent the formation of the larger ribosomal FMET tRNA complex that initiates protein synthesis.
Initiation. So they stop it before it even starts.
Exactly. Most other protein synthesis inhibitors interfere with elongation, adding amino acids to the chain. Oxazolidinones stop the process right at the starting line. This unique mode of action allows these agents to be active against strains that are resistant to multiple other antibiotics.
Like what kind of resistant bugs?
including penicillin-resistant strains of S. pneumonia, as well as methicillin-resistant MRSA, vancomycin intermediate VISA, and vancomycin-resistant VRSA, strains of Staphylococcus, and even the notoriously difficult-to-treat vancomycin-resistant Enterococci, or VRE.
Wow, hitting the big scary ones, MRSA, VRE.
Precisely. Their activity profile is focused there. Linezolid is active against the vast majority of gram-positive organisms. All the Staphylococcus, streptogramins, enterococci, gram-positive anaerobic cocci, and gram-positive rods like Corynebacterium, Nocardia, and Listeria.
Is it static or cytal?
It's generally bacteriostatic against enterococci and Staphylococcus, meaning it halts their growth. But it may be bactericidal against streptogramins, actually killing them outright.
Okay, gram negatives.
Very poor activity against most gram-negative aerobic bacteria. So it's definitely not a broad-spectrum gram-negative agent.
Got it. Gram-positive specialist. What about mycobacteria?
Kiwi.
Mycobacterium tuberculosis is moderately susceptible to linezolid, as are most rapidly growing mycobacteria. But critically, MAI, Mycobacterium avium intracellulare, is frequently resistant. Ketazolid seems to have a very similar activity profile to linezolid based on current data.
Okay. Resistance to these, how does that happen? It's newer, so maybe less resistance.
Resistance has emerged, unfortunately. Observed in Enterococci and Staphylococcus, it's most commonly due to point mutations in the 23S RNA gene, which is part of the 50S ribosome where the drug binds.
Mutations at the binding site.
Yes, because bacteria often have multiple copies of these 23S RNA genes, significant resistance typically requires mutations in 2 or more copies to overcome that redundancy. More recently, and quite concerningly, a transferable methyltransferase has been described. This confers resistance via ribosomal modification, similar to what we saw with macrolides, and because it's transferable, it can spread more easily.
Uh-oh. How common is resistance?
Linezolid resistance remains relatively low overall among normally susceptible organisms, but some facilities are reporting an increasing frequency in Enterococci, including documented cases of nosocomial transfer within hospitals. Ketazolid may be active against some linezolid-resistant isolates due to subtle binding differences, but extensive clinical data on this is still lacking. More research needed there.
Okay. ADME. How are they handled by the body? Linezolid first.
Linezolid is exceptionally well absorbed after oral administration. It boasts a remarkable bioavailability of essentially 100%.
Wow. 100% oral bioavailability.
Yes, which means nearly all of the drug you take by mouth gets into your bloodstream. This makes oral and intravenous dosing exactly the same, 600 milligrams usually, which dramatically simplifies patient management and switching from IV to oral.
Very convenient. Half-life. Distribution.
Its half-life is about 4 to 6 hours. It's approximately 30% protein-bound. Linezolid distributes widely to well-perfused tissues, and importantly achieves favorable distribution into the central nervous system, making it useful for certain CNS infections where gram-positives are involved.
Metabolism. Excretion.
It's metabolized non-enzymatically, meaning it doesn't rely on those liver CYP enzymes that can be inhibited or induced by other drugs, which avoid a lot of interactions. It breaks down into inactive metabolites. About 80% of a dose appears in the urine, roughly 30% as active drug, and 50% as the breakdown products. About 10% appears as products in feces.
Kidney function matter. Dialysis.
The manufacturer currently doesn't recommend dose adjustment in renal insufficiency, although some studies have suggested potential accumulation of the drug or its metabolites in severe renal dysfunction, so monitoring might be prudent. Linezolid and its breakdown products are efficiently eliminated by hemodialysis, so the drug should be administered after dialysis sessions to ensure appropriate dosing.
Okay. Tetazolid. How's it different?
Tetazolid is administered orally and parenterally as a prodrug, tetazolid phosphate. This is rapidly and completely hydrolyzed to the active form, tetazolid, after administration. It is also very well absorbed after oral administration, with bioavailability over 80%.
Good bioavailability, too.
Yes. Tetazolid exhibits greater protein binding, around 70–90%. It has a longer half-life, approximately 12 hours, which conveniently supports once-daily dosing.
Once a day is nice. Elimination.
Minimal elimination of unchanged drug in the urine. Instead, it primarily undergoes sulfation, a type of metabolism mainly in the liver, and is excreted mainly in the feces. A different pathway than linezolid.
Okay. Therapeutic uses. Mainly for those resistant gram-positives.
Exactly. Linezolid is most commonly given as 600 milligrams twice daily, either orally or IV. For long-term therapy of mycobacterial infections, lower doses or reduced frequency, like 300 milligrams twice daily or 600 milligrams once daily, might be used strategically to minimize side effects. Tetazolid is typically given as a 200 milligram IV or oral dose once daily.
Okay. What specific infections? Skin? Pneumonia?
Both linezolid and titazolid are FDA approved for the treatment of complicated skin and skin structure infections caused by susceptible streptococci and S. aureus, including both MSSA and MRSA. A significant finding for titazolid is that a shorter 6-day regimen was shown to be non-inferior to a 10-day course of linezolid for these infections.
Shorter course is always good. Pneumonia.
For respiratory tract infections, linezolid is approved for treating community-acquired pneumonia due to S. pneumonia and also for nosocomial pneumonia hospital-acquired, caused by S. aureus, including MRSA. A key randomized trial in patients with MRSA pneumonia specifically showed that linezolid had similar or even slightly better outcomes compared to vancomycin.
Better than Vanc for MRSA pneumonia. That's big.
It was a significant finding, making it a strong alternative. Studies of titazolid for pneumonia are currently ongoing.
Okay. What about VRE?
Yes, linezolid is very commonly used for a variety of serious infections caused by vancomycin-resistant Enterococcus faecium, VRE. This is a critical indication, as VRE is highly resistant with very limited treatment options.
Lifesaver for VRE infections.
It really has been. It has also found use in combination therapy for extensively drug-resistant tuberculosis, XDR-TB, various non-tuberculous mycobacterial infections, and infections due to nocardia. Its activity against these difficult-to-treat organisms underscores its importance.
Okay. Now, the adverse effects. These can be serious, especially long-term.
Yes, particularly with prolonged use. Myelosuppression, suppression of bone marrow activity is a notable concern.
Affecting blood counts.
Yes, this can manifest as anemia, low red cells, leukopenia, low white cells, pancytopenia, low counts of everything, and most commonly, thrombocytopenia, a decrease in platelet count. Thrombocytopenia typically appears after about 7 to 10 days of treatment, sometimes longer.
Is it reversible?
These effects are generally reversible upon drug discontinuation, but for patients at risk of bleeding, those with pre-existing low platelets, or those receiving therapy for longer than 2 weeks, platelet counts should be carefully monitored. Titazolid, based on early data, may have a lower propensity for causing myelosuppression compared to linezolid, which could be a significant advantage, but more long-term data is needed.
Okay, monitoring blood counts is key, especially if therapy is longer than 2 weeks. What about the mitochondrial toxicity?
Yes, more concerning, especially with prolonged treatment, typically weeks to months, are the mitochondrial toxicities that patients receiving linezolid can develop.
What kind of toxicities?
These include peripheral neuropathy, nerve damage in hands and feet, optic neuritis, inflammation of the optic nerve leading to vision loss, and lactic acidosis, a dangerous buildup of lactic acid in the blood.
Wow. How long does it take for these to show up?
These effects typically manifest after prolonged treatment durations, usually at least 6 weeks, sometimes months, although some cases of lactic acidosis have been described after only a few days. The underlying mechanism is believed to be the inhibition of mitochondrial protein synthesis within our own mammalian cells.
Because our mitochondria look like bacteria ribosomes.
Essentially, yes.
Yeah.
Mammalian mitochondrial ribosomes resemble bacterial 70S ribosomes closely enough to be inhibited by the drug. In studies of patients receiving long-term linezolid for drug-resistant TB, the rates were quite high, like 18% experiencing optic neuritis and 64% peripheral neuropathy within the first year.
That's really high.
It highlights the risk with extended use. Due to these potentially severe side effects, linezolid should generally not be used for long-term therapy if equally effective alternative agents are available. Currently, there's insufficient data to fully judge the risk of these mitochondrial toxicities with titazolid.
Okay, serious long-term risks. Drug interactions, MAO inhibition.
Yes, linezolid is a weak, nonspecific inhibitor of monoamine oxidase, or MAO. This means patients receiving concomitant therapy with adrenergic or serotonergic agents like SSRI antidepressants, or those consuming large amounts of tyramine-rich foods like aged cheeses or meats, may be at risk for serotonin syndrome.
Serotonin syndrome, what's that?
It can manifest as palpitations, headache, agitation, confusion, and even hypertensive crisis. For this reason, co-administration of linezolid with SSRIs or other serotonergic drugs is generally best avoided.
Okay, what if someone really needs both?
In situations where patients already on SSRIs acutely require linezolid for short-term treatment, say 10 to 14 days co-administration with very careful monitoring of blood pressure and mental status might be considered reasonable, but it requires significant clinical judgment and caution. Preclinical data suggest that titazolid may have a lower potential for this MAO inhibiting interaction, which would be a welcome improvement if borne out clinically.
Good. Any CYP interactions?
Importantly, neither linezolid nor titazolid is a significant substrate or inhibitor of the major CYP enzymes. This simplifies things quite a bit, avoiding many common liver-mediated drug interactions.
Okay. Let's move to the pleuromutilins. Retapamulin, lefamulin, these sound interesting.
Yes, the pleuromutilins. These are truly unique derivatives of natural products originally isolated from Pleurotus species fungi, discovered way back in the 1950s. Currently, 2 agents are available for human clinical use: retapamulin, which is a topical agent only, and lefamulin, which has the versatility of being administered both orally and intravenously.
How do they work? Mechanism.
Their mechanism of action is distinct and clever. They inhibit bacterial protein synthesis by specifically targeting the 50S ribosomal subunit. Their binding site is strategically located near both the A and P sites of the ribosome, those crucial spots where amino acids are added and protein chains are built.
Okay.
This binding directly results in the inhibition of peptide bond formation, a critical step in building proteins. While there's some overlap with the binding sites of other classes like oxazolidinones, lincosamides, phenicols, and streptogramins, the pleuromutilins possess a unique enough mechanism that cross-resistance with these other classes is currently uncommon.
That's a significant advantage, static or cytal.
Lefamulin's activity against susceptible gram-positive pathogens is typically bactericidal, meaning it actively kills the bacteria, which is often preferred for more serious infections.
Okay. What's their spectrum? Gram-positives, gram-negatives, atypicals.
They demonstrate potent activity against a wide range of gram-positive pathogens, with the notable exception of enterococci, so no VRE coverage, for example. They exhibit very low MICs against staphylococci, including MRSA, and streptococci, including penicillin-resistant S. pneumonia, highly effective against those.
Okay. Strong gram-positive coverage, except enterococci.
Gram-negatives, no useful activity against enteric gram-negatives like E. coli, so not for those common infections. They do, however, have some activity against gram-negatives commonly seen in community-acquired respiratory infections like H. influenza and Moraxella catarrhalis.
Okay. Atypicals, like mycoplasma.
Yes, their activity against atypical respiratory pathogens like Chlamydophila, Mycoplasma, and Legionella species is particularly good, which makes them appealing options for pneumonia. There's also significant and growing interest in using lefamulin for treating sexually transmitted infections based on promising in vitro data against Neisseria gonorrhea and Chlamydia trachomatis.
Interesting potential for STIs. Resistance. Is it common yet?
Resistance to pleuromutilins among typically susceptible organisms is currently rare, which is a very positive sign for this newer class.
Good. How does it happen when it does occur?
The identified mechanisms are generally similar to those seen with other protein synthesis inhibitors. Point mutations that lead to reduced drug binding to the ribosome appear to be the most common way bacteria develop resistance. Additionally, instances of upregulated efflux FUMPs and modification of the ribosomal target through ribosomal protection proteins have also been described, though these seem less common right now.
Okay. ADME, topical versus systemic.
Right. Retapamulin is available only for topical use. Its absorption into the bloodstream is generally very low, which is ideal for a topical agent, although absorption may increase slightly in children or when applied to broken skin.
Okay. Lefamulin for an oral.
Yes. Following intravenous administration, lefamulin achieves peak plasma concentrations of approximately 1.5 to 2 milligrams per liter. The oral formulation of lefamulin has a relatively low bioavailability, around 25%.
Only 25% absorbed orally.
Yes, and it's modestly reduced by food. However, at the higher oral doses that are recommended, peak plasma concentrations approximating those achieved with IV administration can still be reached, allowing for effective oral step-down therapy from 5E. The drug is highly protein-bound, around 95%, and has a half-life of about 12 hours, which conveniently allows for twice-daily dosing.
Elimination.
Elimination is largely of the unchanged drug in the feces, a unique pathway. And importantly, there's no need for dose adjustment in patients with renal or hepatic dysfunction, simplifying its use in patients with compromised organ function.
Okay. Therapeutic uses. Where are they used now?
Retapamulin, the topical one, is specifically indicated for the topical treatment of impetigo in adults and children. It's applied as a thin layer of a 1% cream twice daily.
Impetigo cream. Got it. Lefamulin.
Lefamulin is indicated for the treatment of community-acquired bacterial pneumonia, CABP, with a dose of 150 milligram IV or 600 milligram orally every 12 hours. It offers a new option for this common infection, covering both typical and atypical pathogens well. It is also currently under study for the treatment of skin and soft tissue infections, which could expand its utility in the future.
Okay, CABP is the main indication now. Adverse effects. Well tolerated.
Lefamulin is generally well tolerated, which is always good news. The most common side effects are gastrointestinal, primarily nausea and diarrhea, common across many antibiotic classes.
Any serious concerns?
A notable concern that warrants monitoring, particularly in patients with risk factors for arrhythmia, is the observed prolongation of the QT interval on an electrocardiogram, similar to macrolides. So careful consideration is needed for patients with pre-existing heart conditions or those on other QT prolonging medications.
Okay, QT prolongation risk again, drug interaction.
Yes, both retapamulin and lefamulin are substrates of CYP3A4, that major drug metabolizing enzyme.
Ah, so interactions are possible.
Therefore, concurrent use of lefamulin with strong inducers or inhibitors of CYP3A4 should be avoided or undertaken with extreme caution. Strong inducers like rifampin can rapidly break down lefamulin, reducing its effectiveness. Strong inhibitors like ketoconazole can cause lefamulin to build up, potentially increasing adverse effects, including that QT risk. Always check for interactions.
Okay, next class. Streptogramins. Quinupristin, delphopristin. That's a mouthful.
It is. The streptogramins are a fascinating class known for their synergistic action. These are semisynthetic derivatives of naturally occurring agents originally produced by the bacterium Streptomyces pristinus. For human clinical use, the only streptogramin available is that fixed combination of two distinct components, quinupristin, which is a streptogramin B, and dalphopristin, a streptogramin A. They're precisely combined in a 30.70 ratio. These are more soluble derivatives specifically formulated for intravenous administration only.
IV only. How does that synergy work? Mechanism?
The mechanism is quite clever, demonstrating beautiful synergy. Both are protein synthesis inhibitors that bind to the 50S ribosomal subunit.
50S again.
Yes, quinupristin binds at roughly the same site as macrolides and has a similar effect, inhibiting polypeptide elongation and causing early termination of protein synthesis. Dalphopristin, however, binds at a nearby but distinct site.
What does dalphopristin do?
Its binding is crucial because it induces a conformational change in the 50S ribosome, subtly altering its shape, which then synergistically enhances the binding of quinupristin at its target site. Dalphopristin also directly interferes with polypeptide chain formation itself.
So they help each other bind and work better.
Exactly. The net result of this cooperative and synergistic binding of these two molecules to the ribosome is a significantly enhanced and often bactericidal activity. They actively kill bacteria when used together, more effectively than either alone.
Okay. What's their spectrum? Gram-positives, atypicals.
The quinupristin-dalphopristin combination, often called QD, is active against most gram-positive cocci, including Staphylococci, MSSA, some MRSA, and Streptococci. It also hits organisms responsible for atypical pneumonia, like Mycoplasma, Legionella, and Chlamydophila.
Gram-negatives.
Fundamentally inactive against gram-negative organisms, so not for E. coli or similar bugs.
Static or cytal.
The combination is notably bactericidal against Streptococci and many strains of Staphylococci. But importantly, it is bacteriostatic against Enterococcus faecium, VRE. It inhibits VRE growth rather than killing it outright. This distinction can be important in serious infections like endocarditis, where you prefer cytal activity.
Okay, static against VRE, resistance. How does that work with two components?
Resistance mechanisms are distinct for each component. Resistance to quinupristin, the B part, can be mediated by genes encoding a ribosomal methylase, preventing drug binding, or by lactinase enzymes that inactivate type B streptogramins.
Okay. And dalphopristin, the A part.
Resistance to dalphopristin is mediated by genes encoding acetyltransferases that inactivate type A streptogramins, or by staphylococcal genes encoding ATP-binding efflux proteins that actively pump type A streptogramins out. These resistance determinants are typically located on plasmids so they can spread.
So resistance to the combo requires resistance to which part?
Crucially, resistance to the QD combination is always associated with a resistance gene for the type A streptogramin, dalphopristin, highlighting its importance in the synergy. Furthermore, those methylase genes that confer macrolide resistance can also render the QD combination bacteriostatic instead of bactericidal against staph and strep, making it less effective where a killing effect is strongly preferred, like endocarditis.
Okay. ADME, 4 only, right? Short half-life.
Yes, administered exclusively by 5E infusion, typically over at least 1 hour, due to formulation and potential for local irritation like phlebitis. The half-lives are quite short, about 0.85 hours for quinupristin and 0.7 hours for dalphopristin. Requires frequent infusions, usually every 8 or 12 hours.
Clearance, liver, kidneys.
The principal means of clearance is hepatic metabolism through conjugation. A significant 80% of an administered dose is eliminated by biliary excretion into the feces. Renal elimination accounts for most of the remainder. No dosage adjustment is necessary for renal insufficiency or dialysis. However, hepatic insufficiency significantly increases plasma concentrations, 180% for quinupristin, 50% for dalfopristin, requiring very careful consideration and likely dose adjustment in patients with liver problems.
Okay, watch the liver function. Therapeutic uses. Where does it fit in? VRE.
Yes, QD is approved in the U.S. for complicated skin and skin structure infections caused by MSSA or S. pyogenes. However, its primary and most impactful role has been for the treatment of infections caused by vancomycin-resistant strains of Anaerococcus faecium, VRE. The typical dose is 7.5 milligograms every 8 to 12 hours.
So mainly a VRE drug now?
In practice, yes. In Europe, it holds broader approval for nosocomial pneumonia and MRSA infections. But generally, its use should be reserved for serious infections caused by multi-drug-resistant gram-positive organisms, particularly VRE, as it has largely been supplanted in many areas by newer agents like linezolid or daptomycin that also have potent activity against resistant gram-positives and are often more convenient or better tolerated.
Okay. Adverse effects. You mentioned infusion site issues.
Yes, the most common issues are infusion-related events. Frequently, pain and phlebitis, inflammation of the vein at the infusion site. Patients may also experience arthralgias, joint pain, and myalgias, muscle pain.
How to manage the phlebitis.
To minimize phlebitis and pain, it's often recommended to administer the drug through a central venous catheter, a larger vein access, rather than a peripheral IV if possible. Arthralgias and myalgias seem more problematic in patients with hepatic insufficiency, and these can sometimes be managed by reducing the infusion frequency, finding that balance between efficacy and tolerability.
Okay. Drug interactions. CYP enzymes again.
Yes. Quinupristin dalfopristin is known to be a significant inhibitor of CYP3A4.
Another CYP3A4 inhibitor.
Right. This means concomitant administration of other CYP3A4 substrates may result in significant toxicity due to increased levels of those co-administered drugs. Therefore, caution and careful monitoring are strongly recommended, especially for drugs with a narrow toxic therapeutic window or those known to prolong the QTC interval.
Right.
Lots of potential interactions.
Okay. Next, we arrive at the phenicols. Chloramphenicol. This one has a serious history, right? Last resort.
Yes, the phenicols, most prominently represented by chloramphenicol. A drug now often seen as a true last resort in modern medicine, certainly in developed countries. Chloramphenicol, originally from Streptomyces venezuelae, was introduced way back in 1948, a major milestone then.
Why is it a last resort now? The side effects.
The reason is quite stark and tragic. Chloramphenicol can cause serious and even fatal blood dyscrasias, severe disorders of the blood components produced in the bone marrow. Aplastic anemia is the big fear.
Aplastic anemia, wow.
Consequently, its use is now strictly reserved for treating life-threatening infections, like certain types of bacterial meningitis or severe rickettsial infections, and only in patients who cannot take safer alternative drugs due to resistance or severe life-threatening allergies. Other similar agents, like cyamphenical and fluorphenicol, are primarily used in veterinary medicine now.
Okay. How does it work? Mechanism.
Chloramphenicol inhibits protein synthesis in bacteria and, importantly, to a lesser extent, in our own eukaryotic cells, especially mitochondria. The drug readily penetrates bacterial cells. Its primary action involves binding reversibly to the 50S ribosomal subunit near the binding site for macrolides and clindamycin, explaining some potential cross-resistance.
50S again, what does it block?
By binding there, chloramphenicol prevents the amino acid-containing end of the amino acid tRNA from binding properly to the acceptor site, A site, on the 50S subunit. This critical disruption means the interaction between peptidyl transferase, the enzyme that forms peptide bonds, and its amino acid substrate cannot occur efficiently. The result? New peptide bonds don't form, blocking protein synthesis.
And this hits our mitochondria, too.
Yes, and that's the key to its toxicity. Chloramphenicol can inhibit mitochondrial protein synthesis in mammalian cells. Remember, mammalian mitochondrial ribosomes bear a striking structural resemblance to bacterial 70S ribosomes, making them susceptible. The cells particularly sensitive are the erythropoietic cells, the precursors to red blood cells in the bone marrow. This directly explains its most severe hematological side effects.
Okay, spectrum. It's broad, right? Despite the toxicity.
It possesses a genuinely broad spectrum, yes. It is bacteriostatic against most species, but can actually be bactericidal against key meningitis pathogens like H. influenza and meningitis and S. pneumonia.
Okay, staph, enterococci, rickettsia.
Strains of S. aureus tend to be less susceptible overall, but surprisingly, some isolates of highly resistant MRSA have actually been found to be susceptible. It's also active against Enterococci, including multi-drug-resistant E. faecium. It effectively targets mycoplasma, chlamydia, and rickettsia, making it a crucial alternative for those infections when other options fail.
gram-negatives.
Enterobacterales show variable sensitivity. Pseudomonas aeruginosa is notably resistant, even at very high concentrations. Never use it for Pseudomonas. Conversely, strains of Vibrio cholerae have largely remained susceptible.
Okay. Resistance. How does that happen?
Resistance to chloramphenicol is usually caused by a plasmid-encoded acetyltransferase. This bacterial enzyme inactivates the drug by adding an acetyl group to it. These acetylated derivatives fail to bind to bacterial ribosomes. Resistance can also stem from decreased bacterial cell permeability or from ribosomal mutations altering the target site.
Okay. ADME. Availability. Absorption.
Historically, chloramphenicol was available orally, IV, and topically, like eye drops. However, it's critical that the oral and ophthalmic formulations are no longer available in the U.S. due to safety concerns, though they might be found elsewhere.
So 4 only in the U.S. now.
Essentially, yes, the systemic form is Solm-Tetsuco. The parenteral form is chloramphenicol succinate, which is a prodrug. It has to be hydrolyzed by esterases in the body to become active chloramphenicol.
Does that affect things, the prodrug part?
Yes. The inactive succinate prodrug is rapidly cleared by the kidneys, which can actually reduce the overall bioavailability of the active drug, as up to 30% might be excreted before it even gets activated. In neonates and infants who have less developed kidney function and sometimes lower esterase activity, this can lead to increased levels of the inactive succinate and a delayed peak of the active drug, necessitating very careful monitoring.
Okay. Distribution. CSF.
Chloramphenicol distributes widely in body fluids and readily reaches therapeutic concentrations in the cerebrospinal fluid, CSF, which is a major advantage for treating CNS infections like meningitis. Gets into the brain well.
Elimination. Liver. Kidneys.
The major route of elimination is hepatic metabolism, where it's transformed into an inactive glucuronide metabolite. This metabolite and any unchanged chloramphenicol are then excreted primarily in the urine. For patients with impaired liver function, metabolic clearance is decreased, so dosage adjustments are definitely needed. Interestingly, the drug's half-life isn't significantly altered by renal insufficiency or hemodialysis, so dose adjustment isn't usually needed for kidney problems alone. However, due to all this variability, especially in neonates and children, monitoring plasma drug concentrations is often necessary to ensure both safe and effective dosing. Very tricky drug to dose.
Absolutely. Therapeutic uses.
Strictly limited, right? Extremely limited. Therapy must be restricted to infections where the benefits unequivocally and dramatically outweigh the risks. If other safer, equally effective drugs are available, they should always be used instead. Last resort only.
So like meningitis in allergic patients.
Yes, it remains an important alternative drug for treating bacterial meningitis caused by H. influenza and meningitis and S. pneumonia, particularly in patients with severe, life-threatening allergies to beta-lactam antibiotics and also potentially in resource-limited settings. Dosing needs to be precise, typically 50 mg/kg a day IV divided every 6 hours for children.
And rickettsial diseases?
Yes, for rickettsial diseases, while tetracyclines are preferred, chloramphenicol serves as a crucial alternative for patients allergic to tetracyclines, pregnant women, where tetracyclines are avoided, and children under 8 needing prolonged or repeated courses. Things like Rocky Mountain spotted fever, typhus, Q fever respond well. Dosing is typically 50 mg/kg a day divided Q6 hours, potentially higher for short periods in severe cases, then reduced. Therapy continues until the patient is better and fever-free for 24-48 hours.
Okay. Now, the really serious adverse effects. The blood disorders.
Yes, the hematological toxicities. These are the primary reason for its restricted use. The toxicity is largely attributed to that inhibition of protein synthesis within our own mitochondria.
2 types of blood problems.
Yes. First, there's a dose-related reversible erythroid suppression. This shows up as anemia, leukopenia, or thrombocytopenia. It reflects the drug's inhibitory action on mitochondrial protein synthesis in red blood cell precursors in the bone marrow, impairing iron incorporation into heme. This regularly occurs when plasma concentrations get high, maybe 0.25 big ml, or with large or prolonged doses. While initially reversible, if treatment continues, this can tragically progress to fatal aplasia, complete bone marrow failure.
Okay, dose-related and reversible if caught early. What's the other one? The scary one.
Second, and much more feared, is the idiosyncratic aplastic anemia. This is a rare but devastating reaction leading to fatal pancytopenia, severe deficiency of all blood cell types. Crucially, it often develops without any prior dose-related marrow suppression, making it unpredictable.
Unpredictable and potentially fatal.
Yes. Although the incidence is thankfully low, maybe 1 in 30,000 courses, the fatality rate is very high if complete marrow aplasia occurs. There's also an increased incidence of acute leukemia in those rare individuals who do recover. This idiosyncratic reaction accounts for about 70% of blood dyscrasias due to chloramphenicol. It seems more common with prolonged therapy or repeat exposure. A proposed mechanism involves conversion of the drug's nitro group to a toxic intermediate by gut bacteria, which then damages bone marrow stem cells.
Just devastating. And the gray baby syndrome?
Yes, another devastating adverse effect, particularly in neonates, is the infamous gray baby syndrome. This serious illness usually begins 2 to 9 days after treatment starts, especially in premature infants. Symptoms include vomiting, refusal to suck, irregular rapid breathing, abdominal distension, periods of cyanosis, bluish skin, loose green stools.
Well, great.
Over the next 24 hours, the affected neonates turn an ashen gray color and become limp, flaccid, and hypothermic. A similar gray syndrome has been reported in adults who are accidentally overdosed. Tragically, death occurs in about 40% of affected babies within 2 days of initial symptoms. Those who recover usually have no lasting problems.
What causes it in babies? Why are they so vulnerable?
The mechanisms are primarily twofold. First, a developmental deficiency of glucuronidase transferase, the liver enzyme needed to metabolize chloramphenicol into its inactive form. Neonates just can't break it down efficiently. Second, inadequate renal excretion of the unconjugated active drug by their immature kidneys. These two factors combine to cause a dangerous buildup of active chloramphenicol. Levels are usually very high, often over 100 big ml, when this syndrome occurs. Extreme caution needed in newborns.
Absolutely. Drug interactions, CYP inhibition.
Yes. Chloramphenicol significantly inhibits hepatic CYP enzymes, particularly CYP2C9 and CYP3A4. This prolongs the half-lives of other drugs metabolized by this system, like warfarin or phenytoin. Failure to recognize this can lead to severe toxicity from the other drugs. Conversely, concurrent use of potent CYP inducers like phenobarbital or rifampin can drastically shorten chloramphenical's half-life, potentially resulting in subtherapeutic levels, meaning the antibiotic might not work. Dangerous given its use for life-threatening infections.
Okay, a very potent drug with very serious risks. Last agent for today, mupirocin. This one's topical, right?
Our final agent is mupirocin, a unique topical protein synthesis inhibitor. Mupirocin was initially isolated from Pseudomonas fluorescens and is actually a mixture of several related compounds called pseudomonic acids. It's notably effective against gram-positive bacteria and is specifically designed for topical use only applied to skin or nasal passages, not taken internally.
How does it work?
Mupirocin inhibits bacterial protein synthesis by reversibly binding to and inhibiting an enzyme called isoleucyl tRNA synthase. This enzyme is crucial for attaching the amino acid isoleucine to its specific transfer RNA molecule, a vital step before that amino acid can be added to a growing protein chain. By blocking this enzyme, mupirocin leads to a depletion of charged isoleucyl tRNA, effectively stopping protein synthesis that requires isoleucine.
Okay. Any cross-resistance issues? Spectrum.
A key advantage is that there is no known cross-resistance between mupirocin and other major antibiotic classes. This is invaluable for treating infections caused by strains resistant to many other drugs, like MRSA. Its activity ranges from bacteriostatic to bactericidal, depending on the concentration. It's primarily active against gram-positive bacteria, including Streptococcus pyogenes, MSSA, and critically, MRSA.
Okay, good for Steph, including MRSA, resistance to mupirocin itself.
Resistance can occur at various levels. Low-level resistance typically arises through simple point mutations in the gene for the target enzyme, the isoleucyl tRNA synthase. This slightly reduces the drug's binding affinity. More concerning is high-level resistance. This is mediated by a plasmid that encodes a completely different bypass isoleucyl tRNA synthase enzyme. This bypass enzyme binds mupirocin very poorly, effectively allowing the bacteria to circumvent the drug's inhibitory action entirely and continue making proteins even in the presence of mupirocin. Plasmid-mediated means it can spread.
Okay. Therapeutic uses. Skin infections. Nasal decolonization.
Yes. Mupirocin is available as a 2% cream or ointment for dermatologic applications, and specifically as a 2% ointment for intranasal use. The skin preparations are indicated for treating traumatic skin lesions like cuts or scrapes and impetigo that are secondarily infected with susceptible S. aureus or S. pyogenes.
And the nasal ointment.
The nasal ointment is specifically approved for the eradication of S. aureus nasal carriage. This is important because carrying staph in the nose is a common source of self-infection, especially pre-surgery or for patients prone to recurrent skin infections or in healthcare settings. The consensus is that patients who benefit most from mupirocin prophylaxis, nasal decolonization, are those with proven S. aureus nasal colonization combined with risk factors for distant infection, like upcoming surgery, or a history of recurrent skin soft tissue infections.
Okay. Adverse effects. Pretty safe topically.
Finally, adverse effects. Mupirocin is generally very well tolerated topically, which is why it's a popular choice. It may cause mild irritation and sensitization at the site of application. If it accidentally gets in the eyes, it can cause irritation that might take several days to resolve.
Anything systemic to worry about?
A specific caution relates to the polyethylene glycol, PEG, present in the ointment formulation. PEG can be absorbed from damaged skin, particularly over large surface areas. Therefore, application of the ointment to extensive areas of damaged skin should be avoided in patients with moderate to severe renal failure to prevent the potential accumulation of polyethylene glycol, which could theoretically cause systemic issues. A reminder that even topical drugs can sometimes have systemic implications if absorbed significantly.
Good point. Okay, wow. That was a deep dive indeed.
We covered a lot of ground.
We really did. And there you have it, a truly comprehensive journey through the intricate world of protein synthesis inhibitors. We've unpacked the incredible diversity within this group, haven't we? From the broad-spectrum tetracyclines with their unique four-ring structure and these tricky case insulation quirks.
Don't forget the dairy.
Never. To highly specialized agents like fidaxomicin, targeting C. diff with pinpoint accuracy, and mupirocin, that topical powerhouse for staph decolonization.
And we've seen how each class targets the bacterial ribosome in distinct yet equally critical ways. Whether it's blocking the A site like tetracyclines, inhibiting the crucial translocation step like macrolides, or uniquely preventing the very initiation of protein synthesis altogether like the oxazolidinones.
Right.
This deep understanding of their precise molecular mechanisms directly translates into their specific therapeutic uses, their often complex resistance patterns, and their unique side effect profiles, from the truly dreaded gray baby syndrome of chloramphenicol to the cardiac concerns with macrolides and that potential for myelosuppression or mitochondrial toxicity with long-term oxazolidinones. You can now really grasp that intricate dance between the drug and the microbe.
You've truly gained a deep understanding of these vital antimicrobials. You've connected the dots from molecular action to real-world clinical applications and the significant challenges posed by bacterial resistance. You are now equipped with knowledge comparable to the elite professionals in this field. That was our goal.
Indeed. And understanding these specifics isn't just, academic. It's absolutely crucial in the broader context of antimicrobial stewardship and our ongoing dynamic battle against resistance. The constant evolution of bacterial resistance mechanisms means that the study, development, and critically, the judicious use of these drugs is an ever-changing field. It requires continuous learning and adaptation from all of us.
It really makes you wonder, doesn't it? As bacteria continue their relentless evolution, developing new ways to resist our current therapies, what do you think will be the next major breakthrough in targeting bacterial protein synthesis? And what entirely new challenges might that breakthrough bring to the forefront of medicine?
That's a profound and essential question for the future of infectious disease medicine indeed. The race absolutely continues.
Absolutely. Well, thank you for joining us on this very deep dive into the fascinating, complex, and truly vital world of protein synthesis inhibitors. We hope you feel more informed, empowered, and ready for that ongoing dance of discovery and defense.